Hi, everyone. Welcome to our Blood Cancer United Community Ask an Expert session today on myeloma. I am thrilled to be joined by Dr. Craig Cole. Dr. Cole, would you like to tell us a little bit about yourself?
Yes, thanks for inviting me. And my name is Craig Cole. I'm a myeloma physician at Hermanos Cancer Institute in Detroit, part of Wayne State University's medical school. And I'm also at Michigan State University's medical school in Lansing. And those are the two places that I practice. And I've been doing myeloma research and taking care of myeloma patients for about 20 years.
Thanks so much for being with us, Dr. Cole. We're thrilled to have you here to offer your expertise and a few questions we've received from our community members. The first question is, does talquetamab TGVS or TALV cause increased side effects over time, or is there another reason why side effects may present later?
Yes. So to kind of level set, talquetamab is a bispecific antibody used to treat relapsed or refractory myeloma. And so it engages T cells, which are the cells which eat up cancer cells, and it engages myeloma cells through a protein called GPRC5. And GPRC5 is on myeloma cells. So when you receive talquetamab, it brings those T cells and the myeloma cells together, and the T cells eat up the myeloma cells, therefore treating the myeloma. The trick about the receptor GPRC5 or the protein GPRC5 is this also on skin cells. And so it's on what we call endothelial cells, which are all over the body. And so when people receive talquetamab, it also has effects on the skin cells. And so people can have rashes and nail changes. They can have, the skin in your mouth will cause a dry mouth and altered sense of taste, and sometimes smell. And it can cause some weight loss also. The trick is that the drug also has kind of a long half-life that it lasts about 21 days in the body, between 12 and 21 days in the body. So when you receive it, it's constantly doing things. So unlike a lot of therapies where you receive an injection and you can just have a side effect right away, it takes time for some of these side effects to come about. And especially when you're talking about skin cells, that it takes, especially because your skin grows from the inside out, it can take time to see those effects because it takes time for the effects of the talquetamab to take place and for it to then rise to your skin for you to actually see it. So like the skin and nail changes can start about a month after starting a treatment and can persist over time. And so, you get a dose today, but you actually don't see the skin effects for about a month later, and then they can continue after that. Some of the dry mouth and altered sense of taste, you receive it on day one, and it can take about 2 to 3 weeks to start seeing those. Because again, the skin cells grow a bit more slowly, and that the effect then takes a longer period of time. And some of the things like weight loss can take, 2 to 3 months to actually see, because again, it takes time for these side effects, especially with the skin, to kind of set in. The good thing it is rare for those symptoms and signs to escalate over time, that they usually reach a steady state and then they can start to abate over time. And especially the weight loss is can abate over time. But during that time that you're receiving it, it's important to talk to your doctor about some of the side effects that you're having. Engage a nutritionist or a dietitian to compensate for any weight loss and changes in dry mouth and skin. And the good thing is that, after giving talquetamab for a number of years, we now know a lot of solutions for a lot of those problems. And so they're really good lotions and nail strengtheners for some of the skin and nail disorders. For the dry mouth, there's um, we can use, candy, like lemon candy, to kind of help with the saliva and use supplements for the saliva. And for the weight loss, of course, maintaining your weight and making sure that you take in enough calories to compensate for the weight loss, which can occur 3 months after the first dosing. So the good thing is that we have a lot of ways to compensate for a lot of those side effects, but they do take time to occur.
Thank you so much for helping us understand the impact of this treatment in particular. How close are we to a cure for myeloma?
Yeah, so how close are we to a cure for myeloma is a super good question. Um, so it kind of depends on your definition of cure. And this is what, we're going to be meeting in the next several months, the International Myeloma Working Group, to address this very issue. So, I guess, to reframe the question is, have we cured patients already with myeloma? The answer is yes, that there are people that we call exceptional responders, that people who we give our standard therapy to, and then they don't relapse for, decades at a time, and they end up dying of other things. We still, keep them on the maintenance therapy. We may still keep them on some type of treatment to keep the myeloma at bay, but but they end up succumbing to other things besides myeloma. And are those people cured? Those people have never had their myeloma come back, and they didn't die of myeloma. Therefore, people can call that a cure. We also have, a small number of patients who have received some of the advanced T cell redirection therapies, specifically CAR T, that have received, one therapy and then have again been exceptional responders, where they have remained in long-term remissions for years and years and years. And are those people cured of myeloma? At least so far, after 5, 6 years of observation, their myeloma hasn't come back. So therefore, that may be someone who is, again, functionally cured of their disease. What I consider cure is something that is generally applicable, because not everybody can receive CAR T. Not everybody is exceptional responders. And really, what we need is a cure for myeloma that you can get at a myeloma center of excellence, or that you can go to your general care doctor to receive a treatment that will put it in long-term remission. And we're working really hard at that. So I think that, are we on the cusp of curing myeloma for for some patients? Yes. Are we on the cusp of curing it for the general population? We're really working hard at that. And I would say, with the current velocity of research going on in myeloma, and how exciting, and how we have really broken through barriers of addressing access to these excellent to these these superior treatments, we're working on that. And I think the collision of working on health equity, on working on the science to find excellent drugs for myeloma, and having a better understanding of the biology of myeloma will get us to that cure. The one important thing that, as a patient, to be aware of about us curing myeloma is that empowered patients are the ones that will be cured of this disease in the future. That the patients who know, that have discussed with their doctors about curing myeloma, we're getting those second opinions at myeloma centers, and being updated regularly on forums such as this about that empowerment will lead you to those cures faster.
Thank you so much. I really appreciate that. And that so aligns with the work that Blood Cancer United is always trying to do,
Absolutely.
informing and equipping patients with the best and most up-to-date information so that they can really advocate and gain access in ways they may not have thought possible. So, our final question comes from a member with a history of chronic lymphocytic leukemia and acute promyelocytic leukemia, and they are asking, what are MGUS markers they need to watch out for?
Yes, so one thing that we know is about so MGUS, the monoclonal gammopathy of uncertain significance, long word, which means that you have a very small number of plasma cells that are mutated in the body, and that there's a very low risk that those few mutated plasma cells in the body could expand and grow into a disease like myeloma. Though the other feature of those few plasma cells is they produce a protein, and you can measure that protein in the blood to tell you if somebody has a monoclonal gammopathy or not, and if they could have, again, a low risk of turning into myeloma in the future. And so, how do we know if somebody has a monoclonal gammopathy? Well, we look for that protein. We look for that protein produced by those mutated plasma cells. And that protein test is a test called a serum protein electrophoresis. So they get the blood and they put it in a gel and they turn on the electricity. And the electrophoresis is that it will it will separate the different proteins in the blood into by different weights. And you can pick up on the one single protein produced by those mutated plasma cells and can give you a number of how much of that protein is in the blood. So the serum protein electrophoresis is a test to detect the protein produced by the plasma cells. And that's how we diagnose MGUS. So one test is a protein electrophoresis. Another test is the serum free light chain assay. So what's the serum free light chain assay? Sometimes those plasma cells won't produce antibodies or protein, but they'll produce fragments of those proteins, and those fragments of the protein won't show up on the serum protein electrophoresis, but will show up on the light chain assay. And the usual thing is that about 80 to 75% of patients will make an intact protein that the SPEP will pick up, and the remainder will produce those light chains that the serum light chain will pick up. And so if you do those two tests together, that it will pick up MGUS about 99% of the time. One last test, so serum protein electrophoresis, free light chain assay. The third test is a test called the immunofixation. And the immunofixation fixes the type of protein it is. So it can tell you if what type of antibody there is, so you know how to follow it in the future. Because if that protein goes up and up and up and up and up, the more that we worry that the plasma cells have grown and grown and grown. And then we worry about people having smoldering myeloma, another precursor to myeloma, or true and true multiple myeloma. So the tests that we follow are the SPEP, measuring the protein produced by those plasma cells, the free light chains, the other protein that can be produced by the plasma cells, and then the immunofixation, which tells us the type of protein produced by those plasma cells. And it gives us a number that we can follow through time. The CLL and the history of chronic lymphocytic leukemia and acute promyelocytic leukemia is kind of an unrelated. We've looked at this, and the closest diseases that are related to plasma cell disorders and MGUS are more like autoimmune diseases, but it doesn't track well with myeloid diseases. So those two entities are pretty separate. But MGUS is actually very common, that about 8 to 10% of people over age 50, depending on where the studies are done, will have an MGUS, but only a small minority of those people will actually develop myeloma.
Thank you so much. And thanks, Dr. Cole, for answering our community member questions today. The information expertise is greatly appreciated, and we appreciate your time.
Thank you. Thanks for inviting me.